Good evening, everyone. Welcome to the 102nd Blue Health Virtual Seminar. Blue Health Virtual Seminar is a platform that allows healthcare professionals to discuss current management updates of different health-related topics for better patient care. And this platform is sponsored by Ankara Technologies for the LearnNat project with Blue Health Ethiopia. So LearnNat is a comprehensive platform dedicated to offering valuable information on pregnancy, childbirth, and initial stage of childhood development, catering to both parents and expectant parents. Additionally, LearnNat offers a convenience of doctor's consultation for individuals seeking professional advice. Moreover, LearnNat features a marketplace that showcases a diverse range of maternity-related products, providing a one-stop solution for the need of expectant mothers and parents. And LearnNat has entered into a collaborative partnership with Blue Health Ethiopia, with the primary objective of enhancing the expertise and knowledge of LearnNat's medical professionals, particularly focusing on the intricate aspect of pregnancy. This strategic alliance is geared towards providing specialized training and upskilling opportunities for doctors associated with LearnNat, ensuring they are well equipped and with the least insights and advancements in the field of obstetrics. And a little background on Blue Health. Blue Health is a medical consultancy company founded by medical doctors and a computer engineer, and we aim to be an influential healthcare leaders in creating a skilled community through easily accessible knowledge in preventive medicine. And I'm going to be your host, Adam Getachew. I'm the co-founder and CTO at Blue Health Ethiopia. And it's a pleasure to have Dr. Dawit Mesfin here with us again to give us a presentation on operative vaginal delivery topic. And Dr. Dawit Mesfin, those of you who don't know him yet, he's an obstetrician and gynecologist, and he's also an assistant director of obstetrics and gynecology department at Dawit Memorial Hospital. There you go.
Okay, thank you, Adam. Good evening, all. So, as he tried to mention, Dr. Dawit, obstetrician and gynecology from Dawit Memorial Hospital. Hope we had a lot of sessions in the past months, and today's session will be part of it with obstetrics background, which is an operative vaginal delivery. Okay, so so basically, we are going to see on operative vaginally on the main issues that we need to discuss about. And the main, basically, operative deliveries could be a cesarean section or a vaginal delivery. So basically, on the vaginal delivery, we do have these vacuum deliveries, forceps delivery, and destructive delivery. But on this session, we only focus on just instrumental delivery with vacuum and forceps delivery. So basically, to start with introduction part, operative vaginal delivery, as the name implies, basically it means the operator uses some devices so that he's going to assist the mother and result in expulsion of the baby, okay, from the intrauterine to the extrauterine life, basically. So what just happened whenever we use these operative vaginal deliveries, we are basically augmenting or increasing the force that the woman is creating. Okay, so we're not creating some new force, but basically we are creating some amount of augmentation for the mother so that it will help the maternal pushing effect. Okay, and whenever we use these operative vaginal deliveries, we do have two purposes. One of it is just pulling, which is traction. Okay, the other one is rotation. Okay, so among these functions of using this operative vaginal delivery, traction is going to be considered to be the most important function of this operative vaginal delivery instruments. Okay, so traction is the main instrument. So coming to the most interesting history backgrounds of usage of this instrumental delivery, the first person who was taught to use the first time forceps for the first time is called to be Peter Chamberlain, and in 1601 to 1683. And the type of forceps that he was using was illustrated on the image as you can see here. Okay, and this is a guy who used it for the first time. The the second interesting person was Thomas Denman, and this guy first created some kind of law, with which he called it Denman's law. And what he said was, in order to use these forceps, okay, the head of the baby has to be in the perineum for at least 6 hours. Okay, that was what he was mentioning, and the pain has to cease. And then that was the time that we need to use the forceps. So basically, his consideration was the head has to be in the perineum for 6 hours, and when the pain has subsided, then that was the time to use the forceps. That was the first law in 17 to 18, that he created. Okay, but after that, there was an obstetric tragedy, which we call it the triple obstetric tragedy. Okay, this was caused by on Wales princess, which Princess Charlotte is. And what happened was this guy, he's an obstetrician. He's called Sir Richard Croft. He was an obstetrician who was following this princess, and whenever the time she started to have labor, he was following her. Okay, so what just happened was she was in the first stage of labor, which means in the latent and the active first stage of labor, for around 26 hours. Okay, and then after 26 hours, she entered into second stage of labor. And in the second stage of labor, still she waited for another 24 hours. Imagine now she reached more than 48 hours, more than 2 days on labor. Okay, so she stayed in the second stage for 24 hours, and finally she get to deliver a male stillbirth, which is 9 pound, around 4.1 kg. Okay, and finally after 4 hours, the mother also, the Princess Charlotte, has died due to unknown complication. Well, that was what is written on literatures. Okay, so after that, the the obstetrician, after 4 months, he was having very disturbing moments after the delivery of this Princess Charlotte, and he killed himself by a gun. Okay, so basically, the mother has died, the baby has died, and then finally, the obstetrician has died. And these three phenomena was called a triple obstetric tragedy. Why we usually come this tragedy to the issue of obstetrics in intraoperative vaginal delivery is that by that time the issue of forceps delivery was created. It was before this tragedy that forceps was invented, but due to the acceptance of forceps at the British society, it was not being practiced. Okay, so basically, if operative vaginal delivery was being applied during the second stage of labor before it is too late, okay, there was a possibility of salvaging the baby, and there was also a possibility of salvaging the mother. Okay, the the postulated cause for days of the Princess Charlotte was intra-abdominal collection, intra-abdominal bleeding. But sooner or later, after 2, 3, 4 years after her days, it was postulated that at Yale University that her cause of death was secondary to pulmonary embolism. So basically, we raised the issue of this triple obstetric tragedy. Okay, appropriate usage of instrumental deliveries during the second stage of labor could salvage the baby as well as the mother. That was the initial thing that we need to consider whenever we thought of this Prince Charlotte's days. Okay, so coming to the incidence of usage of this obstetric forceps instrumentus and vacuum. Okay, the incidence is around 14.8% for forceps delivery, and it's around 18.7% for a vacuum. Okay, it's a little bit remote study, but it's done in Ethiopia. And but in up to date 2021, the percentage of forceps delivery is considered to be 0.5% of vaginal delivery, and the vacuum delivery is considered to be around 2.6% of the vaginal delivery. So basically, nowadays, the practice of this operative vaginal delivery is somehow decreasing as compared to the previous times, okay? There are different postulated theories why this operative vaginal delivery is getting lower as compared to cesarean section, okay? There are some postulated reasons. So one of the things is, as we all know, these instruments has their own complication, okay? For example, if we take vacuum is thought to be safer for the mother, but it is considered to be safer, riskier for the baby, okay? And whenever we consider the forceps is thought to be dangerous for the mother as well, less riskier for the baby, okay? So just the usage of these instrumental deliveries nowadays, due to the complication to the baby, as well as complication to the mother, created some kind of frustration on the obstetricians and residents and interns, okay, and the midwives, trained midwives. So basically, no one is in need of taking risks and involved in medical legal issues. So basically, nowadays, people tend to prefer on cesarean section rather than trying for vacuum and forceps delivery. So basically, the rate of cesarean delivery, as you can depicted on your facilities, is higher as compared to vacuum and forceps deliveries, okay? And the other most important thing is the issue of training, okay? The issue of training is somehow very important. Nowadays, as I've tried to explain, the capability of residents, R3s, R4s, R2s, performing vacuum and forceps delivery properly without complicating the baby and the mother is less likely. So basically, this came from proper training, okay? Proper lack of proper training. So this has also contributed for the decrement in the usage of these operative vaginal delivery techniques. Let alone vacuum, let alone the destructive delivery, but also the vacuum and forceps delivery is somehow decreasing nowadays. So basically, these things need somehow training and somehow experience. Okay, so this is a curve showing operative deliveries comparison as compared to the cesarean section in US, and it's from 1992 to 2020. So as you can see, the usage of these operative deliveries like the forceps and vacuum is somehow lower than that of the cesarean section, as you can see on the graph. Okay, so when we come to the prerequisites for usage of operative vaginal deliveries, we can use some mnemonics, okay? So as you can see, A stands for anesthesia. Always, whenever we plan to give this vacuum or forceps delivery, we need to give local anesthetics so that we may need to give them episiotomy and so on, okay? So local anesthetics has to be provided properly, okay? And in the best setups, we even need to give them epidural anesthesia, which is which possibly decrease labor-related pain. Okay. The other one is the bladder. Always, the bladder is some obstacle. It's considered to be a CPD agent. So basically, we need to empty the bladder before we attempt any obstetric vaginal delivery, both vacuum as well as forceps delivery. Okay. The other one is cervix has to be dilated properly. Okay, so there are some institutions, there are some guidelines, some writings who prefer to use vacuum delivery at which is above 8 centimeter dilated. Okay, but usually in our guidelines and so on, it is preferred to use any operative vaginal delivery, both the vacuum delivery as well as forceps delivery when the cervix is fully dilated, okay? Fully dilated. That is the most important thing because whenever it is being done properly, we are not going to harm the cervix. We are not going to create some kind of cervical tear, okay? The other one is always the head has to be engaged, okay? If we apply this vacuum or forceps when the head is not engaged, then it's going to be very traumatic, okay? we may create some kind of uterine rupture, cervical tear, vaginal tear, any other perineal tear. Okay, it's just like bringing the baby from the uterus, which is unengaged floating baby from the uterus. It's just like that. So always the appropriate time to apply vacuum as well as uh, forceps is when the station reaches to 0, okay, which is at the level of the ischial spine and above. That is the most important time to apply this operative vaginal deliveries. And the other one is the fontanelles and the direction, the position, basically. Okay, so always the head has to be in the vertex position. Okay, so the vertex position means the occipito anterior or occipito posterior position, basically. Okay, so if it is that, so if that's so, then we can apply the operative vaginal instrument, the vacuum and the forceps without any difficulties. So basically, we need to check for the position of the head. Okay. So the other most important thing is always the membrane has to rupture. Okay. So without the membrane being ruptured, we cannot apply or we cannot assess the position of the baby head. Okay, whether there is caput or not, we cannot assess for any CPD and so on. So always, whenever we planning to apply this operative vaginal delivery instruments, we need to rupture the membrane. Okay. The other thing is clinical pelvimetry. Okay. So always we need to have adequate pelvis so that the baby is possible to get out of it. Okay. Otherwise, we are not going to put on a CPD. Okay, or grossly contracted pelvis. We cannot apply vacuum or forceps. It will result in devastating injury to the baby as well as to the mother. Okay. The other one is always we need to stick with the indication. Okay. If we give proper time for at the second stage with adequate uterine contraction and everything with proper manner, definitely the baby will go out. Okay. But trying to apply obstetric vaginal delivery instruments before the time allowed, then we may affect the proper uh, uh, transition of the baby, okay, with the proper rotations of the baby through the birth canal. So basically, we have seen in the last session the cardinal movement of the baby through the birth canal. So whenever we apply earlier from the expected time, we may affect this cardinal movement, okay? So basically, the head could be impacted at somewhere before it gets out. So we always need to stick with indications, and the proper timing is very important whenever we plan to apply instrumentals delivery. Okay. The other most important thing is we need to apply these operative vaginal delivery instruments inconsistent with the maternal pushing effort. Okay. If the maternal contraction is absent, then we are not going to pull. Okay. So always we need to pull it inconsistent with the maternal pushing effort. Okay. That is what we call it augmentation. Okay. So we are, as we have seen on the definition, we are basically augmenting her maternal contraction, her maternal pushing effort. Okay. We're not creating some kind of new type of pressure. Okay. So basically, we are augmenting her contraction. That will affect the delivery easily. Okay. And the most important thing is we need to stop it. If there is no descent, if there is no progress of pulling efforts, okay, then we need to be generous enough to abandon that procedure, okay? If sometimes we may be somehow እልህ ልንጋባ እንችላለን, okay? Basically, we may attempt these instrumental deliveries beyond the expected number of times. So that definitely will harm the baby, will kill the baby, and also will definitely harm the mother as well. So always, if there is no, if we reach to the time where there is a so-called failed instrumental delivery, then we have to abandon and we have to go for cesarean section. Okay, so that's the most important thing all of us has to practice before we apply the instrumental delivery. Okay. Okay. The other one is indications for operative vaginal delivery, which is actually both for the vacuum as well as for forceps. Always whenever there is prolonged second stage of labor. Here, always what we need to be sure is currently if the mother has adequate uterine contraction, if there is possible descent and so on. The cutoff points and the cutoff point is for preemies is 3 hours and 2 hours for multis, okay? And 1 hour additional if she is on epidural anesthesia, okay? So always prolong the second stage of labor, then we can apply the vacuum or forceps. The other is most importantly non-reassuring fetal state pattern at the second stage, okay, at the second stage. And then that could be also an indication for operative vaginal. But always we have to be sure, okay, even if we have this non-reassuring fetal status, we need to see the station, okay? If the station is high, like in -1, with fully dilated cervix, with non-reassuring fetal pattern, we cannot pull it out from that position, okay? So always we need to check the other parameters as well. It's not non-reassuring by itself at second stage. It's not basically not the indication, okay? We need to consider the adequacy of the baby, the station, okay, whether it is possible to apply the instrument or not. Okay, that's what we need to consider. Okay, the other thing is cardiac and neurologic diseases during the second stage. Okay, because these things might affect or might aggravate the condition, the underlying condition. For example, if she has a cardiac condition, underlying cardiac condition, neurologic underlying condition, usually we need to shorten it out. Okay, shortening the second stage could be very necessary. Okay, so in that case, we may need to apply these operative vaginal instruments, operative vaginal instruments. Okay, the other is contraindication for both forceps and vacuum that we need to suspect is if there is any gross CPD or contracted babies. Okay, in that case, we never have to attempt even to apply forceps and vacuum. This is very dangerous for the baby as well for the neonate, I mean, for the mother as well, okay? The other thing is any fetal demineralization disease like osteogenesis imperfecta and so on, which is actually diagnosed prenatally and so on, okay? In that case also, we may affect the baby, okay? While we are trying to push, women pull with forceps and vacuum, okay? So basically, if we diagnose this thing prenatally during the antenatal follow-up, then we have to defer using the operative vaginal delivery instruments, okay? Other collagen disorders, bleeding tendencies, okay? Any suspected or confirmed macrosomia, okay? These are common contraindications that we need to focus for both forceps and vacuum delivery. Okay, so the other part that we need to check is the types of forceps that we need to use. Normally, the optimal types of forceps that we consider these days is called the flow forceps and the outlet forceps, okay? We abandon to use the high forceps and we usually abandon to use the mid forceps, okay? Mid forceps basically is considered to be above station +2, okay? So any station above +2, we don't recommend using any instrumental delivery. By the way, this classification is not only for forceps, but also it works for vacuum as well, okay? We are not trying to pull a baby when the station is -1 or when the station is -2, okay? Basically, or 0. So it has to be as much as possible below +2 station, below +2 station. So the optimal forceps and vacuum types that we should practice is the low forceps and the outlet forceps. So the low forceps, we consider it to be plus or less than or equals to 2 centimeter, plus 2 station, okay? So here we do have two types of forceps, okay? Those forceps that, by the way, forceps has two functions, okay? We can use as a traction method, and we can also use it for rotation purpose, okay? So there are two types of low forceps that we can be able to rotate less than 45 degree, and those that we can be able to rotate more than 45 degree, okay? So basically here, the baby is somehow a little bit higher in the station. Still, it is below +2, but it's a little bit higher from plus and so on. So there is a possibility of rotating it more than 45 degrees, okay, with a forceps. So we do have this kind of forceps. The other is outlet forceps, which is another optimal and mostly practiced type of forceps in vacuum, okay? This is when the station is more than +3 and so on, okay? Here, without even application of the obstetric instrument, the scalp is visible in the ithroides, okay? Just when we can see the head just over the perineum, distending the vulva, okay? And the fetal scalp is visible, and the sagittal suture, everything is palpable, okay? So in this case, we call it an outlet forceps, okay? Any instrument that we use on the station +3 and above, +3 and below, +3, +5, +5, then we consider to be outlet vacuum or outlet forceps. So here we cannot rotate it more than 45 degrees, okay? If the station is past +3, basically there is no place for rotation more than 45 degrees, okay? So this what we basically here, rotation is not applicable, rather more of traction is the function here, okay? Traction is more of the function here, okay? So coming to vacuum assisted delivery, okay, it's called the venous delivery, as I have tried to explain it earlier. The prevalence is around 18.7%, okay, 18.7. It's a little bit higher as compared to the vacuum, forceps delivery. It is thought that vacuum, I don't know how, but it is thought that vacuum is considered to be a little bit safer as compared to forceps. There is no written document, but for the mother, it is thought that the vacuum is a little bit safer, okay, but not for the baby, okay. And considering this assumption, most of the midwives, most of the residents, even seniors, they prefer to use vacuum rather than forceps, okay. And the usage, as I've tried to explain earlier, it's 4 to 1%, 4 to 1% in ratio. So vacuum seems to be the safest according to health professionals, basically. Okay, so it has two functions. The main function, as I have tried to explain, it is traction. Okay, but sometimes also we may need to uh, use this vacuum for as well for rotation purpose. Okay, as you can see on the image, okay, we do have different types of vacuum devices. Okay, we'll see that later on. We have plastic, those with a plastic cap, those with a metallic cap, and so on and so on. Okay, so coming to the indication of, this vacuum. The indication is basically, as I have tried to explain earlier, prolonged second stage, nerve reassuring fetal pattern, cord prolapse in the second stage. Okay, cord prolapse in the second stage, basically, and shortening second stage, like I've tried to explain earlier. Those with cardiac problems, neurologic problems, maternal distress, respiratory problems, eclampsia, preeclampsia, okay? And these conditions might necessitate us to deliver the baby with an expedient manner, okay? So in this case, whenever the woman reaches to second stage of labor, we don't wait up until she reaches to prolong its second stage. So basically, we may apply forceps or vacuum in order to expedite the process of delivery, okay? So these are the possible indications. The contraindications, as I have tried to explain earlier as well, okay, CPD is a gross contraindication, okay? Fetal conditions like mineralization, bone mineralization disorders, bleeding disorders, okay? Non-vertex presentation. Basically, other than the vertex presentation, okay, we cannot apply vacuum for face presentation. We cannot apply it for breech, malposition, and other conditions, okay? So always we apply this vacuum only for vertex presentation, which is occipito anterior or occipito posterior position, okay? Other than this, we are not going to practice the vacuum, okay? And the other is the head has to be engaged, okay? That was a prerequisite that we have tried to discuss, okay? So the station has to go down, specifically +2 and below, okay? That was the indication to apply this vacuum. If it is more than +2 and above, then it is not the safest way to apply vacuum, okay? The other and most important thing is for preterms, okay? For preterms, specifically, there is not such a cutoff point, standard cutoff point, but um, uh, usually it is preferred not to use vacuum before 34 weeks of gestation. The reason why we don't use this is the fetal skull is somehow pliable, okay? It's so very weak. So whenever we apply this vacuum, there could be compression and decompression injuries, okay? So these injuries will fracture the skull and will fracture soft tissues beneath the skull, okay? So basically, intracranial hemorrhages and different brain injuries could appear on those less than 34 weeks of gestation or less than 1.5 so this is 1.5 kg or 1,500 grams, okay? And HIV positive females, the risk of transmission, vertical transmission is a little bit higher. So we don't apply to use vacuum. So these are the most important contraindications that we need to check. Okay, so coming to the parts of vacuum, okay, we do have different parts. Oh, one of it is the cup, the vacuum pump, okay? This is, as you can see, this is a vacuum pump. The vacuum pump, basically, we do have different vacuum pumps. This is more of a hand pump, okay? This is a hand pump, but also we do have some pedal pumps and electrical pumps, okay? So we do have different types of vacuum pumps. The other one is suction cups. Suction cups, we do have these plastic suction cups, okay? And the other one is we do have metallic suction cup, as you can see on the figure, okay? On the figure, this one is the metallic cup, and this one is a plastic cup, okay? So traction could be, we do have some chains or device. For example, here on the plastic cup, we do have some devices that will help us to hold and put some traction, okay? Sometimes we do have chains that are attached to the vacuum cup, and with this instrument, handle instrument. So the other one is suction tube, which is basically will be attached to the cup so that it will transmit the pressure, okay? And the suction tube and the pressure gauge, this one, okay, is very important. We are not basically using it nowadays strictly, okay? We just think that it creates pressure, but always whenever we apply instrumental delivery, we always need to specifically vacuum, okay? We always need to check the pressure gauge, okay? The pressure reading over the gauge. Okay, so whenever we are thinking of applying vacuum, there are prerequisites that we need to check, okay? Always check the prerequisites for instrumental application, the mnemonics, okay? The mnemonics always has to come to our mind first, and then we need to check the extractor and suction cup placement area, okay? So as you can see on the image, okay, we do have the anterior fontanelle and we do have the posterior fontanelle. Always the cup has to be placed around 3 centimeters above the posterior fontanelle, in front of the posterior fontanelle, okay? This is what we call it, the flexion point, or it's called the pivot point. ምን አለ መሰላችሁ ቤዚካሊ ፒቮት ፖይንቱ ማግኘታችን ጥቅሙ ምንድን ነው? ስንስብ በቫኪዩም አፕላይ አድርገን ስንስብ ፍሌክሽኑን የልጁ ፍሌክሽንን ጠብቀን ነው መውጣት ያለብን። አላማችን ያ ነው። ኦኬ እንደምታዩት አሁን እዚች ጋር ኢሜጁ ላይ we do have different diameters። አሁን እዚች ጋር የምታዩት ዲያሜትር በአሯ ላይ የምታዩት ዲያሜትር it's called the suboccipital-brachmatic diameter ይባላል። This suboccipital-brachmatic diameter is the shortest diameter that the baby's head could possibly pass the maternal external orifice basically. Okay? ስለዚህ ስንስበው በዚህ በኩል እንዲወጣልን ነው with the shortest head diameter እንዲወጣልን አስበን ነው የምንስበው። Okay? So always, in order to do that, we need to maintain the flexion of the head. Okay? ሄዱን እዚህ ጋር አፕላይ ፎር ኤግዛምፕል ፍሌክሽን ፖይንቱ ወደ አንቴሪየር ፎንታኒሎ አስጠግተነው ከሆነ ለምሳሌ እዚች ጋር ከሆነ አፕላይ ያደረግነው ፍሌክሽን ፖይንቱን ዴፊኒትሊ ስንስበው ልጁ ኤክስቴንድ ያደርግብናል። ኤክስቴንድ ካደረገብን ደግሞ ሾርተስት ዳያሜትርን አናገኘውም። ስለዚህ በሾርተስት ዳያሜትሩ መውጣት ያቅተዋል ማለት ነው። and the baby will stuck there. Okay? So always flexion poinታችን ማግኘታችን የህፃኑን አንገት ፍሌክሽኑ ሜንቴን አድርገን ለመውጣት ነው with the shortest diameter ጭንቅላቱ እንዲወጣ እንዲረዳ ነው okay so always whenever we apply the traction ለመጀመሪያው ወደ ታች ነው ቀስቱን እንደምታዩት እዚህ ጋር okay ይሄ ቀስት the broken line ይታያችኋል ይመስለኛል okay the first thing that you need to do is downward ነው okay the first thing is downward traction ነው የምናደርገው this direction we'll come to that downward and then vertical and then upward no okay that's how you should apply the traction okay the only point that we need to check the flexion point is in order to maintain the flexion of the head okay ገና ሳይወጣ extend አደረግነው ማለት it's going to be very difficult for us to extract the baby out okay that's why we need to check always the fetal head okay the sagittal sutureን properly ማግኘት ይኖርብናል anterior እና posterior fontanine properly delineate ማድረግ ያስፈልገናል and then ልክ ከposterior fontanine 3 to 2 cm ወደፊት ሄደን የምናገኛት ፖይንት ፍሌክሽን ፖይንቷን ማወቅ ያስፈልገናል እዛች ጋር ነው ክሬት ማድረግ የሚኖርብን ማለት ነው ኦኬ ሌላው ማወቅ ያለባችሁ ነገር እዚህ ጋር whenever you apply this cup always ቲሹ እንዳይገባብን እርግጠኛ መሆን አለብን ኦኬ maternal tissues usually might enter through the cup so unknowingly ብናደርገው ያንን during traction we are going to cause a very devastating vaginal tear okay so that will be በጣም devastating and it's a cause for PPH by the way so always we need to check apply ከማድረጋችን በፊት ውስጡ ካፕ ውስጥ ምንም አይነት maternal tissue ገብቷል አልገባም የሚለውን we have to be sure enough okay so I hope you understand how to apply vacuum apparatus okay so basically as I have tried to explain earlier we do have two types of vacuum cups okay we do have this plastic cup and we do have this metallic cup the plastic cups they are considered to be the easier to apply application is not that much difference okay I don't think it's that much difference okay it is okay it is easier to apply both the plastic and the metallic cup over the head one thing that you need to be sure is you need to be sure that no tissue is inside the behind the vacuum cup okay whether it is metallic or plastic okay that's the most important thing but whenever we come to the complication related to traction with plastic cup and metallic cup okay with plastic cup the injury scale is very low while it is higher in case of metallic cup the reason behind is the pressure created with a metallic cup is a little bit higher than the pressure created by the plastic cup አሁን ለምሳሌ ይሄንን ፕላስቲክ ካፕ ብታዩ ቅድም ፕሬሸር ጌጁን እዩት የምላችሁ ለዚህ ጋር ነው ኦኬ ፕላስቲክ ካፕ ላይ ቤዚካሊ አፕላይ ስናደርግ within 1 minute ይሄኛውን ያህል ኪሎግራም ፐር ሴንቲሜትር ስኩዌር 0.8 ኪሎግራም ሴንቲሜትር ስኩዌር ፕሬሸር ክሬት እናደርጋለን within 1 minute ነው ኦኬ but when you come to this metallic cup እዚህኛው ፕሬሸር ሌቭል ላይ ለመድረስ 0.8 ላይ ለመድረስ በአንድ ጊዜ አይደለም with every 2 minutes በ0.2 kilogram per meter square ፕሬሸሩን እየጨመርን ነው መድረስ ያለብን በአንድ ጊዜ በአንድ ሚኒት like this like the plastic cup we shouldn't reach to 0.8 kilogram per meter square pressure level ላይ መድረስ የለብንም ማለት ነው so that has its own reason okay because this device metallic device has its own complication over the scalp okay but whenever we see the pressure created and the comfort created while we are applying traction definitely the metallic cup is comfortable now full ለማድረግ okay and the tendency to sleep የማድረግም እድሉ በጣም ዝቅተኛ ነው okay and በተለይ occiput posterior ከሆነ occiput transverse even difficult occiput anterior positions ላይ metallic cup-ን መጠቀም በጣም dislodge የማድረግ ፌል የማድረግ እድሉ በጣም ዝቅተኛ ይሆናል ማለት ነው ስለዚህ ፌሊሪቲ ሬቱን ብታዩትም around 16% ነው for plastic 9% ነው ይቀንሳል ዲታችመንት የማድረግ እድሉም የሜታሊክ በጣም ዝቅተኛ ነው okay so basically this is how you need to know what you need to know between these two cups okay So the other most important thing that you need to see on vacuum suction traction is the artificial caput secondum that is created by the vacuum device. It's called the Chigan ይባላል. Okay, Chignan ይባላል. Basically, this Chignan, it's not as such a very harmful thing for the baby. Usually, this will resolve off. Okay, resolve off within 48 hours. But Chignan መኖሩ ምንድነው ጥቅሙ? Basically, appropriate traction force create እንድናረግ ይረዳናል. Okay, create እንድናረግ ይረዳናል. And also detach እንዳያረግብን ወይም pop off እንዳያረግብን ይረዳናል. So Chignan is something that we always see whenever we apply vacuum over the fetal head. Okay. The other most important thing whenever you apply traction, ምንድነው? ፍሌክሽን ፖይንታችን ላይ ነን አይደለም? ቅድም ያለው ነገር ማለት ነው። ፍሌክሽን ፖይንታችን ላይ ነው አይደለንም የሚለውን ማወቅ መቻል አለብን። otherwise ፕሮፐር ፍሌክሽን ፖይንት ላይ ካላረግ ነው ኦኬ ወይ አሲንክሊቲዝም እንጨምራለን። ኦኬ ያ ማለት ሳጁታል ሱቸሩ ወደ ሌፍት ሳይድ እንዲሄድ ወደ ራይት ሳይድ ወይም ወደ ላይ ወደ አፕዋርድ ወይም ዳውንዋርድ አፕሮች እንዲያደርግ እናደርገዋለን። ያ ደግሞ ሞር ኢምፓክትድ እንዲወጣልን ሳይሆን ሞር ኢምፓክትድ እንዲሆን ያደርጋል። ኦኬ ሶ ፍሌክሽን ፖይንቱን ፕሮፐርሊ ማወቅ before application of vacuum is very, very important. And the other most important thing is we need to check for the tissue. Okay? Before you apply the vacuum device, check whether there is any maternal tissue behind the cup. Any maternal tissue. Because unknowingly, if we pull that one, definitely we are going to create a very devastating tear over the vagina. So that will create a very significant bleeding. Okay? So mind you, always check for the tissue, check for flexion point. Okay? And the other thing is how you apply the traction. Okay? So always የመጀመሪያው step downward ነው. Okay? Downward ነው. Downward ማድረጋችሁ it will help you to traction as well as a little bit of rotation. Okay? ጭንቅላቱን ወደ ታችም traction apply ታደርጋላችሁ and somehow ደግሞ internally rotate እንዲያደርግ ታደርጉታላችሁ ማለት ነው. And then you make it horizontal as you can see on the picture. Okay, horizontal apply ታደርጋላችሁ and then ልክ ፔሪኒየሙ distend ሲያደርግ then you make it vertical. Okay, and just when the head is going out you are going to remove the vacuum capun remove ታደርጋላችሁ ማለት ነው። ወይም you're going to disconnect. Okay, disconnect ታደርጋላችሁ. Okay, so there are certain things that could result in pop-off. Pop-off ወይም sleep-off እንዲያደርግብን የሚያደርጉ የተወሰኑ ኢሹዎች አሉ። Okay, whenever we are using a vacuum device. የመጀመሪያው ቅድም እንዳልኳችሁ ነው። maternal tissue ወይንም any scalp electrode ሞኒተር የምናደርግበት internal fetal ሞኒተር የምናደርግበት እቃ ውስጥ between the fetal head and the cup ገብቶ ከሆነ definitely እዛ ጋር ሊክ ያደርጋል. So it will dislodge ያደርግብናል ማለት ነው። The other most important thing is incorrect technique. Okay? Flexion ፖይንታችንን properly ካላገኘ ነው ወይ ወደ ግራ ወይ ወደ ቀኝ ወይ ወደ ላይ ወደ ታች አፕላይ አድርገነው ፓራሚዲያን አፕላይ አድርገነው ከሆነ definitely properly pulled ሆኖ አይወጣልንም። ስለዚህ it will stuck there and it will definitely pop off ያደርግብናል ማለት ነው። And the other one is እንግዲህ ካፑቱ ያለው ካፑትም በጣም ሲግኒፊካንት ከሆነ ኦኬ ፕሮፐርሊ ፕሬሸር ክሬት እንድናደርግ አይረዳንም። ኦኬ ሶ ያኛው ፖፕ ኦፍ እንዲሆን ያደርግብናል ማለት ነው። ዛዘር ያው እንግዲህ ትራክሽን ስናደርግ we don't need to twist it ወይም ቤንድ ማድረግ የለብንም፣ ሮቴት ለማድረግ መሞከር የለብንም። ኦኬ ይሄንን ስናደርግ ቤዚካሊ ከሄዱ ጋር አታች የሆነው ካፕ ዲስሎጅ ሊያደርግ ወይም ደግሞ ክፍተት ፈጥሮ ሊክ ሊያደርግብን ይችላል ማለት ነው። ስለዚህ as much as possible proper placement and proper traction okay is very important. We are not going to rotate ህፃኑ ሮቴት ለማድረግ we are not going to rotate the cup. rather gently ሆነ traction ነው የምናደርገው and the baby will keep on its own cardinal movement ተከትሎ ይመጣሉ እንጂ እኛ በራሳችን ትራክሽን አፕላይ ነው እንጂ የምናደርገው በቫኪዩም ሮቴት ለማድረግ አንሞክርም። ሮቴት ለማድረግ ከሞከርን ጀስት ዲስሎጅ ነው የምናደርገው ከጭንቅላቱ ጋር ያለውን አታችመንት ነው ቤዚካሊ እንዲለቅ የምናደርገው ሶ ዛት ኢት ዊል ሊክ ፖፕ ኦፍ ያደርግብናል ማለት ነው። ዛዘር ሞስት ኢምፖርታንት ቲንግ ኢናዲኬት የሆነ ፕሬር ክሬት ካደረግን ቅድም እንዳልኳችሁ 0.8 ኪሎግራም ፐር ሜትር ስኩዌር ፕሬር ሌቭል ላይ በአንድ ሚኒት ውስጥ መድረስ መቻል አለበት። ከዛ በታች በሆነ ፕሬር ጌጅ ለመሳብ ብንሞክር ኢት ዊል ዴፊኒትሊ ፖፕ ኦፍ ያደርግብናል። ሶ ኤንድ ዘ አዘር ሞስት ኢምፖርታንት ቲንግ እዚህ ጋር ሜንሽን ያልተደረገው ፕሮፐር ሳይዝ ኦፍ ዘ ካፕ ኢዝ ኦልሶ ኢምፖርታንት። በጣም የፕሪተርም ወይም ደግሞ በጣም ትንሽዬ ካፕ ለቢግ ሄድ መጠቀም የለብንም። and that will also create some kind of dislodgement and pop off ሊያመጣብን ይችላል ማለት ነው። So the whole point is before we apply this thing, we need to thoroughly assess the position of the head. የት ጋ ነው ፎንታኒል ያለው ሱቸሩ የት ጋ ነው የት ጋ ነው ፕሌስ ማድረግ ያለብን እነኚህ ነገሮችን ቤዚካሊ prior to application we need to check it. The other thing is መቼ ነው መቼ ነው ማቆም ያለብን? ያው እንደነገርኳችሁ ነው ኢንስትሩሜንታል ዴሊቨሪ ኢዝ ሰምሃው ቴምፕቲንግ ነው። አንዴ አልወጣ ሲለን we are tempted to try again and again. But always whenever we step ahead of time, we step now and then, the tendency to create complication both for the mother and the baby is highlighted. So we have to be generous enough to stop, with indication. ያ ማለት ምን ማለት ነው? እዚህ ጋር actually there is no as such ይሄን ያህል ፖፕ ኦፍ መኖር አለበት ዲስኮንቲኒው ማድረግ የሚባል ነገር የለም። ያው ይሄ በተለምዶ ነው 3 ጊዜ ሊክ ካረገ 3 ጊዜ ፖፕ ኦፍ ካረገ we need to stop የሚባለው but usually ዲታችመንቱ ፖፕ ኦፍ 3 ጊዜ ከሆነ or በኢች ፑል ምንም አይነት ዲሰንት የማይመጣልን ከሆነ or any for 15-30 minutes ሞክረን የማይመጣ ከሆነ by the way different textbooks they have their own different failure to forceps የሚሏቸው ክራይቴሪያዎች አሏቸው። but basically we need to be sure ፑል ስናደርግ ዲሰንት አለ ወይ የሚለውን ሹር መሆን አለብን። አንዳንዴ ከ3 በላይ ልንጠቀም የምንችልበት አጋጣሚዎች ሊኖሩ ይችላሉ። but always we need to be sure በአንዱም ፑል በሁለቱም ፑል is there any progress የሚለውን ማወቅ መቻል አለብን። በአንዱም ወይም በሁለቱም ምንም አይነት ፕሮግረስ ከሌለ then we may need to discontinue rather than going for the third or the fourth pull. ስለዚህ it is our individual decision and our individual decision very very important in case of application of instrument. Because as I have tried to explain earlier, it is very tempting, it will encourage us to use more and more force. So that is very dangerous for the mother as well as for the baby. The other one is failed vacuum. የምንለው መቼ ነው? ቅድም እንዳልኳችሁ ያው 3 ፑል which is commonly practiced ነው። 3 ፑል ሞክረን ምንም አይነት ፖፕ ኦፍ ካረገብን or if there is no descent with each pull ምንም አይነት እንትን ከሌለ descent ከሌለ then we may consider it as a failed vacuum. So the other most important thing that we need to consider is complications associated with vacuum. Now ቅድም እንዳልነው vacuum is tend to be safer for the mother, not for the baby. The baby will end up in very devastating complications sometimes, if it is inappropriately applied. Maternal complication, as I have tried to explain, it is most commonly related to not properly applying the vacuum. ቅድም እንዳልነው በሄዱና በካፑ መሃል ማተርናል ቲሹ እንዳይገባ መጠንቀቅ ነው ያለብን። if any maternal tissue between the head and the cup kagaba, and if we apply some traction, definitely we are going to tear up the vagina and the cervix. And so as much as possible we need to be careful. And the other thing is, as I have tried to explain earlier as well, the prerequisites, I recommend you all to use the vacuum as well as forceps when the cervix is fully dilated. Fully dilated. But there are textbooks that recommend application of vacuum which is more than 8 centimeter. Possible, but we need to be experienced. Sometimes we may come up with some severe complications of tearing of the cervix. Okay, so cervical tear could be common if it is not fully dilated. Okay, or sometimes because whenever we apply in not fully dilated cervix, we may accidentally hold that cervix in between the head and the cup. So that could definitely result in cervical tear and PPH. Okay. The other most important thing is fatal complication. Okay. Fatal complication, maybe you can see on the picture here. Okay. So as you can see here on the first picture, there is vaginal tear. Okay. Or and perineal tear associated with the application of vacuum. Okay. And the baby here in the middle, as you can see, scalp laceration due to improper application of the vacuum device. Another like the subgaleal hematoma, hemorrhage, cephal hematoma, okay, with repeated application of vacuum device, okay, could end up in cephal hematoma and subgaleal hemorrhage, okay. Usually, the subgaleal hemorrhage do not cause a suture line, okay, but while the cephal hematoma has a tendency to pass the suture line, okay. So both of them could be a complication of improper application, improper traction, and severe attempts of vacuum device. As you can see, the caput secundum is also severe in this kind of, and also facial nerve palsy related to uh, the sixth nerve palsy related to facial nerve damage due to inappropriate vacuum application, intracranial hemorrhage, even though it's very rare, okay? Even though it's very rare in case of vacuum application, sometimes they may end up in this kind of hemorrhage, okay? The other is forceps, okay? The second part of obstetric instrument that we need to consider is forceps, okay? Yeah, forceps is considered to be safer for the baby, okay, not for the mother, okay, because it is associated with application problems, application traumas for the mother, okay, most of the time. So forceps is considered to be safer for the baby, but not for the mother. When we see the indications, basically it's the same as vacuum, but sometimes forceps we can use it for after coming care of breech, okay, for face presentation, okay, and for other indications which are not applied for vacuum, okay? We'll see them in some part area, okay? The other is contraindication. It's almost all the same for vacuum, the same as that of the vacuum. So here is the parts of the vacuum. As you can see, the vacuum has different parts, okay? The first one is a blade, and the blade has two curves. As you can see here, the orientation of this uh, just the blade of the forceps is designed in relation to the maternal genital tract architecture. Okay, basically the maternal genital tract is a J-shaped, somehow. Okay, so the pelvic curve is designed in relation to the maternal genital tract. Okay, so this, as you can see my cursor, okay, the outside curve and the outside curve, and it's called the pelvic curve. Okay, we say cephalic curve because it is in relation to the fetal head. Okay, the fetal head, cephalic curve. So the inner curvature, okay, the inner curvature is considered to be the cephalic curve, but the upper and the lower curvature is called the pelvic curve. Pelvic curve, it's because it is aligned in relation to the maternal genital tract curve, okay? And it's called cephalic curve because it's designed based in relation to the fetal head. That's why it's called cephalic curve የተባለው ማለት ነው። Okay, so basically we do have different types of blades አሉን። እንደምታዩት እዚህ ጋር fenestrated type አለን፣ pseudo fenestrated አለን, and sometimes we may have the solid type of blades ሊኖሩ ይችላሉ ማለት ነው። And also we do have the shank። እንግዲህ ይሄ shank, it is the area which connects the blade with the lock. Okay, ብሌዱን ከሎኩ ጋር የሚያገናኝልን parts called the shank። ያው ብሌዶቹና የብሌዶቹ ኦሪየንቴሽን እና የሻንኩ ኦሪየንቴሽን could be different for different purposes of forceps. Okay, so we'll see some specialized types of forceps which are different types of forceps which are we'll see how we differentiate them with this blade and shank. So shank and blade are the most important parts. The other one is the lock. Okay, the lock is basically which joins the right and the left side of the blade. Okay, so we do have different types of lock alone. Okay, the English lock, German lock, French lock, sliding lock. We'll see them. Okay, we do have different types of lock in Oralan. And the last part is called the handle. Okay, the handle, which has orientation of our fingers and basically help for handling the forceps. Okay, so as you can see on the figure up there, okay, we do have different types of locks. Sliding lock, pivotal lock, German lock, English lock, French lock, all could appear on one device or could be limited to the different types of forceps. Okay, so basically classification of forceps, we do have three types of forceps. The first one is called the classic forceps. Okay, and we do have rotational forceps, and the other one, the third one, the specialized forceps. We'll come to that. So the first types of forceps are classic forceps. The major function of classic forceps is for traction purpose. Okay, እዚህ ጋር የምታያቸው እዚህ ጋር this is called the Simpson's forceps. Okay, and this one is called the Dealey forceps. Okay, and the other ones like Tucker-McLean forceps. Okay, these are the types of classical forceps. Basically ጥቅማቸው ምንድን ነው? ለሮቴሽን ፐርፐዝ አይደለም የሚጠቅሙን። Okay, these are important for only traction purpose ነው የሚጠቅሙን። Okay, and most of them, not all of them, most of them, they do have the so-called the English lock የምንለው አይነት ኦሪየንቴሽን ያለው ሎኪንግ ሲስተም ነው ያላቸው ማለት ነው። But not all of them. Some of them, in fact, most of them that I have seen on my experience are sliding type of lock ናቸው ብዙዎቹ ያላቸው ማለት ነው። So classical forceps, we do have two types based on the shank. Okay, ሻንኮቻቸው okay parallel oriented የሆኑ አሉ okay or overlapping የሆኑ አሉ okay so parallel orientation ያላቸው ሻንክ classical forcepሶች ሲምሰን እና the dealing ናቸው okay and the overlapping ላይ የሚጠቀሰው most of the time the longest types of forcepሶች ውስጥ የሚጠቀሰው the Tucker-McLean forceps ነው ማለት ነው so Tucker-McLean has two purposes እዚህ ጋር ለትራክሽን መጥቷል okay but sometimes, not sometimes, most of the time, it can also be helpful for rotational purposes. But forceps, no. Most of the time in our institutions, what we found is the Simpson's forceps. Simpson's is the most common in outlet forceps. Okay, the optimal forceps that we usually practice in our hospitals. Okay, so this is classical forceps. The other one is rotational forceps. Okay, the most commonly exemplified type of forceps for rotational purposes are the Killand forceps. Okay, it is usually the sliding type of forceps, no, the metals, and the other is the Tucker-McLean. So you have seen Tucker-McLean both on the rotational as well as in the classical for traction purpose. Okay, so what is so important thing to know in case of this rotational purpose, specifically የኪላንድ ፎርሴፕስ የሚለይባቸው ባህሪዎቹ ምንድን ነው? ከርቬቸሩ ወደ ላይ አይደለም። ኦኬ ዩዥዋሊ ምንድን ነው የምንጠብቀው? ከርቬቸር ዋይዝ ስናይ የሴፋሊክ ከርቭ ቤዚካሊ ወደ ላይ ይሆናል ብለን ነው የምንጠብቀው። ኦኬ okay so this is what we expect in case of most of the classical forceps but in case of this rotational or Killand forceps okay the upper cephalic curve is somehow straight or reversed back okay somehow እንደዚህ ነው so we need to see the orientation of the pelvic curve the pelvic curve for most of classical forceps is oriented upward but in case of Killand it is more of the upper pelvic curve is somehow straight and or sometimes it could be reversed backwards okay so that's something that we need to consider whenever we see rotational rotational type of forceps. So the most important example is Killand forceps. Killand forceps. Okay. The other specialized type of forceps, the most importantly mentioned specialized forceps is the Piper forceps. Okay. ያው እንደምታዩት ፓይፐር ፎርሴፕስ ደግሞ ከሌሎቹ የሚለየው one thing is በሻንኩ ነው። ሻንኩ it's very long ነው። It's not as such straight አይደለም. It is oriented to the back ነው። backward oriented ነው። ፔልቪክ ከርቬቸሩን ስታዩት ደግሞ የአፐር ፔልቪክ ከርቬቸሩ it is more of straight ነው። Okay. So it is helpful for after coming head of bridge. Okay. Bridge ከወጣ በኋላ ጭንቅላቱ ከተቀረቀረ the most important forceps that we need to have in our obstetric ward is the Piper forceps ነው። Okay. So that እንደምታዩት ፔልቪክ ከርቬቸሩ የላይኛው ከርቬቸር ከርቭድ ስላልሆነ ስትሬት ስላልሆነ ፕሮፐርሊ ሄዱ ላይ አፕላይ ማድረግ እንችላለን ማለት ነው። So this Piper forceps is very important forceps which needs to be situated in obstetric ward, and especially if we are attempting vaginal breech delivery. Okay. And if we come up with this kind of after coming head of breech. Okay. So the other thing is application. ቅድም እንዳልኳችሁ vacuum apply ስናደርግ መጠንቀቅ ያለብን ነገሮችን አውርተናል። So this time also we need to discuss on how we apply forceps application. Forceps apply ከማድረጋችን በፊት ልክ እንደ vacuum ሁላ we need to check the position of the head. Okay. As much as possible እንግዲህ vacuum ላይ ያልነው ምንድነው? Always the head has to be vertex ነው መሆን ያለበት። vertex መሆን አለበት። Otherwise either occiput anterior or occiput posterior መሆን አለበት። ትራንስቨርስ ከሆነ ፌስ ከሆነ ብሪጅ ከሆነ አንጠቀመውም። ኦኬ ኢን ኬዝ ኦፍ ፎርሴፕስ አፕሊኬሽን ግን ምን አለ? ቨርቴክስ መሆን አለበት ኦብቪየስሊ። ኦክሲፑት አንቴሪየር ኦክሲፑት ፖስቴሪየርም ከሆነ አፕላይ ማድረግ እንችላለን። ኢን ኬዝ ኦፍ ፌስ ፕሬዘንቴሽን አዝ ዌል ኦኬ ኢፍ ኢት ኢዝ ሜንታል አንቴሪየር ከሆነ there is a possibility for application of forceps. Okay. And the other one is after coming head of breech ከሆነ then we can apply for forceps. ስለዚህ እነኚህ ሁላ ፖዚሽኖች ካሉን ፕሬዘንቴሽኖች ካሉን still there is a possibility of applying instrumental delivery which is forceps ማለት ነው። The other most important thing that we need to check is always ቅድም እንዳልኳችሁ the safest የሚሆነው ኦፕቲማል የሚሆነው low forceps እና outlet forceps ነው። Okay. Which is plus greater than or equals to +2 ከሆነ +3 +4 +5 station ከሆነ it's going to be very important ነው የሚችለው ማለት ነው። ለፎርሴፕስ አፕሊኬሽን ኢዚየር የሚሆነው otherwise forceps is very dangerous ነው። ከ+2 station above ከሆነ ስቴሽኑ በራቀ ቁጥር the tendency to traumatize the vagina, the cervix and even causing uterine rupture is very high. ስለዚህ always we need to check the station before we apply the forceps. So always forceps apply ከማድረጋችን በፊት ቅድም ያልናቸውን ነገሮች ቼክ ማድረግ አለብን። ስለዚህ መጀመሪያ የምታደርጉት የምትይዙት የግራውን ፎርሴፕስ ነው። ኦኬ ልክ እጁ እንደምታዩት በቀኝ እጃችን ጋይድ እያደረገን ወደ ውስጥ እንከታለን ማለት ነው። ኦኬ as you can see here on the figure የግራውን ፎርሴፕስ ኦኬ በቀኝ እጁ ጋይድ እያደረገ ወደ ውስጥ ጋይድ ማድረጉ ጥቅሙ ፕሮፐርሊ አፕላይ ሆኗል አልሆነም የሚለውን ነው። ኦኬ ሶ ልክ ካስገባነው በኋላ እንደዚህኛው ታች ላይ እንደምታዩት ኦኬ አፕላይ እያደረገው ነው አስተካክሎ አስገባው። ኦኬ ልክ እዚህ ጋር ፊክስ እናደርገውና እናስቀምጠዋለን። and then we're going to take the right side of the forceps በተመሳሳይ ፓተርን በሌፍት እጃችን ጋይድ አድርገን እናስገባዋለን። ስለዚህ ጋይድ አድርገን ካስገባነው በኋላ ፋይናሊ ሁለቱን ፎርሴፕስ ፓርቶች ሎክ እናደርጋቸዋለን ማለት ነው። ሁልጊዜ ያው እንደነገርኳችሁ ሞስት ኦፍ ዘ ታይም ያለን ፎርሴፕስ ስላይዲንግ ታይፕ ኦፍ ፎርሴፕስ ነው ብዙ ኦብስቴትሪክ ኢንስቲትዩሽን ላይ አይ ዶንት ኖ ዋይ ግን ሶ ኦልዌይስ the right side of the blade will come above the left one. ስለዚህ ሎክ ያደርግልናል ኢዚሊ ማለት ነው። ኦኬ ይህን ማወቅ አለባችሁ ኦልዌይስ። ሶ የመጀመሪያው የሌፍቱን እናስገባለን and then properly place ካደረግነው በኋላ ደግሞ የራይቱን በተመሳሳይ ፓተርን ሌፍቱን እንዳስገባ ነው እናስገባዋለን ማለት ነው። ሶ ፋይናሊ ካስገባነው በኋላ የምንጠብቀው ፓተርን ምንድነው? the bimalar biparietal ማነር ነው። ያ ማለት እንደምታዩት ብሌዱ ኦኬ ባይማላር እና ደግሞ በሁለቱ ፓሪታል ቦኖች መካከል ባይፓሬታል ኦሪየንቴሽን መሆን አለበት። ዲስ ኢዝ ዘ ፕሮፐር አፕሊኬሽን ኦፍ ፎርሴፕስ ማለት ነው። ግን ይህንን በምታደርጉበት ጊዜ ኢፍ ዩ ፌስ ኤኒ ሬዚስታንስ ካላችሁ ዩ ሃቭ ቱ ዊዝድሮ ዘ ፕሮሲጀር ቤዚካሊ ፎር ዘ ሴክ ኦፍ ዘ ማዘር and for the sake of the baby, okay? Because we always do have options silent. Cesarean section is an option. So we don't need to just go into complications. So basically, so if we have this resistance color, then we are going to stop and we are going to check again the orientation of ከእንደገና check እናደርጋለን. If there is any orientation problem ሆኖ ከሆነ ከእንደገና reapply ለማድረግ እንሞክራለን. If it is very difficult ከሆነ ብናወራም we have to withdraw and we have to go for cesarean section. That's the proper way of application of forceps. Application of the same as vacuum ቅድም እንደነገርኳችሁ ልክ እንደ vacuum ሁላ forcepsም traction apply ስናደርግ መጀመሪያ downward always, okay? Downward will maintain the flexion of the head. የጭንቅላቱን flexion maintain ያደርግልናል. And then it goes for horizontal and finally vulvaውን distend ሲያደርግልን ወደ ውጭ መውጣት ሲጀምር then upward vertically እንስባለን ማለት ነው። The same manner of traction with that of the vacuum. So always እዚህ ጋር እንደምታዩት ላንድማርኮች አለን። እሺ we need to check the fontanelles like that of the vacuum always. We need to check the sagittal suture. Where is it? Okay. We need to check fenestration. Okay. Always a proper apply ከሆነ በፌታል ሄዱና በፌኔስትሬትድ በሆነ ፎርሴፕስ መካከል ከአንድ ጣት ያነሰ ቦታ ነው መኖር ያለበት። ፕሮፐርሊ ፊት አድርጎ ይዞታል ማለት ነው። ኦኬ that's a proper way. ከአንድ ሴንቲሜትር በላይ ከሆነ ስሊፕ የማድረግና ፋሻል ኢንጁሪዎችን የማምጣት እድሉ በጣም ከፍተኛ ይሆናል። So always whenever you have properly apply ስታደርጉት በፎርሴፕሱ ብሌድ እና okay specifically fenestrated በሆነው ፎርሴፕስ ብሌድ እና በፋሻሉ መካከል ከአንድ ሴንቲሜትር ያነሰ ስፔስ ነው ሊኖር የሚገባው ማለት ነው። So these are the landmarks that you need to take. ቅድም እንዳልኳችሁ ትራክሽን አፕላይ ስታደርጉ always downward then horizontal and then you go out, okay? And always whenever before you go out it will distend the vulva አይደለ? ያኔ proper amount of episiotomy መስጠት is very very important, okay? The same thing ልክ ከወጣችሁ በኋላ ዲስአርቲኩሌት ስታደርጉ መጨረሻ ላይ ሎክ ያደረጋችሁት ራይቱን ስለሆነ መጀመሪያ የምታወጡት ራይቱን ብሌድ ይሆናል and then finally left ብሌዱን ታወጣላችሁ ማለት ነው። So this is how you disarticulate and you discontinue the process of delivery. Okay, so complications related to forceps እንደነገርኳችሁ more related to the mother ነው. But it doesn't mean that it doesn't cause anything for the baby ማለት አይደለም. Okay, so fetal and neonatal complications ብዙ ጊዜ they are related to improper application of the forceps ነው. Okay, so asphyxia የማምጣት due to different attempts, trauma specifically, as you can see on the figure, facial nerve injury የማምጣት, brachial plexus injury, corneal abrasion, skull fracture, okay, intracranial hemorrhage, cepal hematoma የማምጣት እድሉ በጣም ከፍተኛ ነው። Okay, even fetal days is also reported. Okay, complications related to cerebral parts, basically remote after delivery of the baby sometimes. Okay, the baby could end up in cerebral parts as well. So these are the commonest fetal and neonatal complications. Okay, maternal complications, injuries. Basically እንግዲህ ኢንጁሪ የሚጀምረው ከላይ ሊሆን ይችላል። ከዩትራይን ራፕቸር ጀምሮ cervical tear, okay, vaginal tear, perineal tear extending to the anus, okay, 4th degree, 3rd degree perineal tear are also could be the injuries or complications related to the mother. Okay, and the other thing is እንደነገርኳችሁ maternal traumas, vaginal traumas could result in PPH, okay, and different attempts atonic uterus, okay, or anesthesia related complications, okay, could also be there. And due to the blood loss, hypovolemic hemorrhagic shock, okay, sometimes dehydration, okay, due to prolonged usage, okay, or related to prolonged labor are also there. Okay, sepsis related to the application, improper application, and also an aesthetic hazards. Okay, due to third degree and fourth degree perineal tear. Okay, fistula formation, other okay delayed and long-term sequelae okay related to back pain, genital prolapse, incontinence. These all are maternal complications. Third maternal complications related to forceps. So basically, health professional has a reason to abandon recently on the usage of forceps, but always it does if we have proper knowledge, if you have proper training, and if you have the courage to discontinue if there is mal application, then instrumental deliveries definitely have benefits. Okay, if they are properly applied, properly used. So when do we say forceps is failed? Like the same as that of the vacuum, okay? If with each pull, if there is no descent, okay, then we may consider as failed forceps, okay? And possible causes, CPD, incomplete cervical dilatation, entrapment of the head, okay? Wrong diagnosis apply ከማድረጋችን በፊት ፕሮፐርሊ ፖዚሽኑን ካላወቅ ነው ኦኬ የት ጋ ነው ሱቸሩ የት ጋ ነው ፎንታኔሉ ፕሮፐርሊ አፕላይ ካላረግን ኦኬ ኢንኮሬክት የሆነ አፕሊኬሽን ካለንም that's also a reason for possible cause for loss of descent and loss of delivery of the babies. Okay, so the other most important thing, ምናልባት the last slide that I'm going to talk now is about the sequential usage of forceps and vacuum. Currently, it's not recommended. Okay, ACOG recommendation, other fetal-maternal society guidelines, they don't recommend the usage of sequential use of vacuum. ያው አንዳንዴ ቴምፕትድ ስንሆን ቫኪዩም አፕላይ አድርገን ትንሽ ከሳብነው በኋላ በፎርሴፕስ የምናወጣበት ወይም ፎርሴፕስ ጀምረን በቫኪዩም የምንቀጥልበት ሲቹዌሽኖች አቴምፕቶች ይኖራሉ, which is wrong basically. Okay, the likelihood of the adverse outcome related to maternal and neonate is very high whenever we use this sequential application of vacuum and forceps. If vacuum fails, it is going to be cesarean section. If forceps fail, it is going to be cesarean section. There is no way to go for another or second instrumental application. Okay, so this is what I have for today, and this one is just to compare vacuum for forceps, which we have discussed thoroughly in the past slides. So if you have any question, you can raise it. Thank you. What is the importance of paramedian flexion point? So basically, yeah, I've tried to explain the importance of median flexion point. The median flexion point is basically meant for keeping the flexion of the head at its point. But if we apply other areas other than the paramedian area, where the cup is placed other than or in the nearby areas of the pivotal point or flexion point, basically whenever we attempt to traction, okay, what we are going to do is we are going to position the head either upward or downward. Okay, so it will there is a so-called asynclitism, okay, which is approaching of the sagittal suture either to the sacral promontory or to the pubic symphysis, which result in CPD. Okay, so basically if we apply at the paramedian flexion point, okay, then we are going to aggravate the asynclitism, possibly resulting in dislodgement as well as difficult to deliver the baby. Is there a need for anesthesia? Was another question. Definitely, whenever we are one of the prerequisites for instrumental delivery is anesthesia. Okay, usually the anesthesia we are going to give is, if possible, epidural anesthesia with concomitant local anesthesia, lidocaine, or in order to block the pudendal nerve. That is the most important anesthesia because it's a very traumatic procedure, okay, somehow for the mother. So basically we need to just to make the procedure pain-free. And the other question is, what was the role of antibiotics while we use an instrument? Currently, guidelines, they definitely don't use, they don't recommend the usage of antibiotics for both vacuum delivery or forceps delivery. But one thing that we need to see is we need to see our contamination, okay? Sometimes the difficult forceps, specifically that result in perineal injuries that extend tear to the anal canal and so on. Sometimes in this kind of situations, we may need to put them on a therapeutic antibiotic regimen, okay? So basically it's individualized discussion, but guidelines, they don't recommend usage of antibiotics for instrumental delivery. And otherwise, thank you for your presentation. And I have one question. Can we use operative vaginal delivery for IFD, and if which type of instrument preferred? If we can't, what is the reason behind? So basically, we are not practicing to use vacuum for application of vacuum for vaginal delivery. Basically, if it is IUFD, there are different options, okay, of instrumental delivery. Uh, operative delivery, operative vaginal delivery, which we didn't discuss it in here, the so-called destructive vaginal delivery. So basically, when the head reaches to the perineum, okay, if in a good gestation, which is greater than or equal to +2, +3, +4, okay, and that time in IFDs, we can apply destructive deliveries, cephalocentesis, and other procedures in order to deliver the baby. So that is the reason behind. And some texts they say they don't vacuum may not create pressure, may not create suction in negative pressure on IFD, but still we can use forceps, okay, always with a maternal pushing effect, But the safest one is, since if it is IFD, the risk of infection is very high. The risk of embolism, pulmonary embolism due to operative vaginal deliveries, maternal trauma, sepsis, infection is very high. So it's good to abandon forceps and vacuum in case of IFD and rather go for just destructive delivery or spontaneous delivery. We usually apply destructive delivery if the head is impacted in the second stage. Okay, in that case, we may go for destructive delivery. Otherwise, if we give it time, basically in an IFD, there is no such indication to apply instrumental delivery at the second stage if it is IFD. So basically, we may need to give it time. If there is proper progress of labor, if there is no CPT and other thing, basically the baby will deliver, the stillborn will deliver, okay? But if it is impacted in the second stage for a long period of time, which is more than like the 3 hours and 2 hours, then that is an indication to go for destructive delivery, not to go for vacuum, not to go for forceps. Can we apply operative vaginal delivery for a patient with previous scar? No. Basically, I don't recommend this one. Okay, I don't recommend application. Yeah, there are institutions uh, that that apply, okay, instrumental delivery for a patient with a scar. Okay, but whenever we are planning to do that, we have to be sure that it's going to deliver. Okay, and always the fear is here. The fear is basically the scar dehiscence, okay? The scar dehiscence. So always after delivery, we have to follow the patient, okay? We have to follow the patient, whether there is any scar dehiscence, profuse vaginal bleeding, okay? We need to check any retained placenta and so on, okay? So there is not such a hard and fast rule of application of vaginal delivery on patients with scar. But always we have to anticipate complications. Okay, we have to anticipate complications in scar patients. Basically, the risk of scar dehiscence is very high because we are just pulling from inside to outside. Okay, we are just hastening the process of cardinal movement. So definitely, okay, there is a possibility of sloughing the scar sites and risk of dehiscence. So always we need to be vigilant enough, and we have to be experienced sometimes whenever we apply vaginal instruments on scar patient. But possible, there are also possible to apply, but always we need to focus on the complications as well. As long as the whole point of delivery is safe mother and safe baby, so always we need to focus on the safer side as much as possible. How are physicians being trained in our setting, since it is a risky procedure? So it's a good question, basically. So here, normally most of us trained from our seniors, okay? So basically, residency program will make you to have access for training with vacuum delivery specifically whenever you are R2 resident, 2 year 2 and year 3 residents. Usually we will start to apply these instrumental deliveries. So basically, there is no such a formal training mechanism. In residency, as you all know, you learn from your seniors, from seminars and different things. And it always needs a courage and being assisted and to practice. So it is individualization. It depends on the individual. If you are passiveness, the tendency to take risk and apply is be very low. So always you need to take risk, apply, learn from your seniors, learn from your mistakes, and so on. That's how the residency program works. Okay, usually that's what's being practiced in our setup. I think no formal training. I think I go through all the questions, Adam.
All right. Thank you so much, Doctor, for the amazing presentation. Also for taking a pretty good amount of time to answering our participants' questions. On behalf of Blue Health and on behalf of Tankara Technologies and through the NELNAT project, and also our participants, we would like to thank you, and hopefully we'll see you on another session at another time pretty soon. Looking forward to that. Thank you so much, Doc.